Hello and welcome to MedCity's Invest program. My name is Arundhati Parmar. I'm the editor-in-chief of MedCity News. We kicked off our annual conference yesterday, and I encourage you all to visit MedCity's event website, Invest, to see the agenda and look at the on-demand content that is already available for everyone to view. So social isolation and feelings of anxiety are not new in our culture. COVID-19 took an already bad situation and made it truly precarious. Meanwhile, our healthcare system is designed to see our mental health as a separate malady divorced from our physical ailments, with little to no communication between primary care providers and behavioral health providers. So how do we move from this concept to a better concept of whole health? That is the thorny question that our panel will discuss today. So I wanted to go ahead and introduce our panel today. So first up, our great moderator is Jessica Zeaske. As a partner at Echo Health Ventures in Boston, Jessica identifies and invests in emerging and growth stage companies. She is a seasoned venture capitalist and board leader, and previously served as director of healthcare investments at GE Ventures, where she invested in precision health companies. Jessica began her career writing software for a startup healthcare delivery company. She received an undergrad degree with honors from Stanford University, graduated from Johns Hopkins School of Public Health with a Master of Health Science and PhD, and completed her MBA with a focus on healthcare administration at Regis University. Welcome to you, Jessica. Then we have Stacia Cohen. Stacia oversees CareFirst patient-centered medical, home, and total care and cost improvement programs, medical and care coordination policies, pharmacy policies, and provider networks. Prior to joining CareFirst, she was vice president of Medicare for BlueCross and BlueShield of Minnesota, where she was responsible for meeting operating income, enrollment growth, administrative budgeting, and key performance targets of the plan's Medicare market segment. Stacia has an associate's degree in nursing from Western Technical College, as well as a Bachelor of Arts in Management and a master's degree in business administration from the College of Saint Scholastica. Before beginning her post-secondary education, she was enlisted as an active duty member of the US Army. Welcome to you, Stacia. Kevin Dedner is the founder and CEO of Hurdle, which provides mental health care for invisible barriers. As a leading culturally intentional mental health provider, Hurdle offers a comprehensive suite of mental health services and self-mastery tools to employers and payers to meet their employees' and members' needs. Hurdle therapists are trained in an evidence-based technique that improves cultural humility and responsiveness. Kevin brings over 15 years of experience in public health, having worked on various issues, including childhood obesity, HIV/AIDS, and tobacco control. A recovering politico, Kevin has worked on political campaigns and successfully led health policy wins. Kevin is a graduate of the University of Arkansas with a degree in political science. He also holds a Master of Public Health from Benedictine University. Welcome to you, Kevin. Then we have Danny Fallin. Danny is the Sylvia and Harold Halpert Professor and Chair of the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health, the only department of its kind housed within a School of Public Health. She also holds joint appointments in the school's epidemiology and biostatistics departments, as well as in the Johns Hopkins School of Medicine's departments of medicine and psychiatry. In her role as chair, she is leading efforts to build a portfolio of research, education, and practice on mental health and the workplace, a critical area for public mental health, including recently founding a Center for Mental Health in the Workplace. She has also contributed to a recent literature monitoring the impact of COVID-19 on our nation's mental health. She earned her PhD in genetic epidemiology from Case Western Reserve University. She also holds a BS from the University of Florida, Gainesville. Welcome to you, Danny. I'm going to turn it over to Jessica right now, who will moderate. But for all in attendance, please feel free to send questions in the chat And Jessica will try to weave the questions from the audience for the panel as throughout the content and programming today. Thank you very much, and over to you, Jessica.
Well, thanks so much. It is a delight to be here and looking forward to our discussion today. I think I could just spend hours with this group of experts in this field, and it is such an important field, as Arundhati spoke about in the beginning. So let me just, to kick this off, let's have each of the panelists just a few sentences about your day job. I will start just because to get to know me. I do invest in my day job. Echo Health Ventures, we invest on behalf of Arkansas, BlueCross BlueShield, Blue Cross of North Carolina, and Cambia. Now, in that, I have the privilege of working with some great CEOs, great innovative approaches. And as we look at this mental health, whole health, there's so much more work to be done here. So let me go ahead and turn it over to the panelists, tell a few comments about their day job. Kevin, you're starting.
Okay, hi, I'm Kevin Dedner. I'm the founder of Hurdle. We are an early stage mental health company, really specializing in providing culturally competent care. We train our therapists in an evidence-based technique that helps them develop more cultural humility and self-care. And that's how I spend my day, leading this company.
Hi, everyone. As mentioned, I'm Dani Fallin. I have the privilege of chairing the Department of Mental Health in the Bloomberg School of Public Health. As was mentioned, the only department of its kind housed in a School of Public Health, which shows the commitment of the Bloomberg School to the intersection between physical and mental health in all of public health. So I'm thrilled that you are all on this webinar today. I think it's great to see so much interest in a topic I feel so strongly about. And I would say that, my personal way of addressing and pushing forth public mental health is by leading a department that does, research as well as educating our future leaders and practice and communication with the community to forward this agenda of public mental health. Happy to be here.
Hi, I'm Stacia Cohen. As the Executive Vice President of Health Services at CareFirst Blue Cross Blue Shield, in my day job, I try to change the mental health status quo in several distinct ways core to our nonprofit mission of affordable, accessible healthcare coverage. Every day, I focus on driving transformation of healthcare quality, equity, affordability, convenience, and access to care through the acceleration of value and outcomes-oriented provider payment models, care support and advocacy programs, and through community partnerships where health happens, where we live, learn, work, play, and seek care to address upstream determinants of health. And through data and analysis, understand what kind of truths the data is telling us about health and, more importantly, about health disparities, such that we can focus on improving access, affordability, and outcomes for all we serve. I'm thrilled to be part of the panel today. Thanks.
Well, thanks. And Stacia, let's just stay with you for a minute. Having worked in this field, and take us back 10, 15 years ago, what is a patient experience like? Just walk us through a little bit what that was like 10 to 15.
Sure. I actually began my career, I'm a registered nurse in addition to the various and sundry other things I do in my day job. I began my career working on an inpatient locked psychiatric unit where I worked for many, many years. I would say, despite our collective efforts, mental health and physical health continue to be seen as distinctive and separate instead of two parts of a whole. That was very true 15 years ago. And while I think it's better than it was then, we've not made enough progress on this front. We have made progress recognizing and addressing comorbid incidents of depression and other mental health concerns in populations who have chronic illness. We've made relatively less progress in addressing chronic medical conditions in populations suffering from severe and persistent mental health issues. Findings from a number of national studies show that adults with these conditions continue to die on average 25 years younger than the general public from leading causes like heart disease, lung disease, diabetes, and cancer. That was true then. It's true now. I would say, despite progress, it continues to be a barrier for many people suffering with mental health and substance use disorders. We continue to treat mental health concerns like character flaws, and physical health as disease. That's an area that I think has continued to get better, but certainly was far more true 15 years ago. And then finally, I would say as modern medicine has gotten increasingly specialized, including in mental health and substance use care, we treat people in increasingly smaller parts, and we put the burden on patients to coordinate with their other providers. That was true 15 years ago. It's better today, but we still have work to do.
Yeah, I would just amplify what Stacia said about the separation between physical and mental health. And it's true, we're getting somewhere, but this was chronically a problem and still is. We see it in the way pay happens. Now we do have more recently parity laws in place, although maybe not always enforced. But for many years, that was not the case. And the other idea of stigma around mental health. So very hard for even care providers to see the relationship between mental and physical health, and to see mental health and behavioral health or substance use problems as an illness rather than as a character flaw. That was already mentioned by Stacia. And I would say also access to information. So when folks have interviewed care providers, particularly physical care providers, about their comfort in addressing mental health needs of their patients, they're uncomfortable. They don't feel they have the right training. They don't feel they have the right referral deck, et cetera. And so figuring out better ways of informing and training physical health providers, and then the reverse, informing and training psychiatric and mental health providers about physical health, is something that is really still a problem.
Great. And Danny, actually, we can just, oh, go ahead, jump in.
Yeah, if I may, I kind of wanted to personalize that question, if I may. Although I've spent my career working in public health, my work now in mental health is very much personally driven. It's sort of, I guess, seasoned with my professional experience. And a few years ago, I started to try to frame mental health as a public health issue, because as Stacia sort of hinted to, I had made this direct correlation between unmanaged stress and untreated mental health issues, in particular for Black men. Black men have the lowest life expectancy of any population. And there's some work by a researcher named Sherman James, who shows how these sociological pressures translate to cardiovascular health problems for Black men. And he coined the construct, we call it John Henryism. In fact, our company started out named Henry Health to sort of honor that legacy of John Henry. But fast forward, my experience is really driven by working myself into mental exhaustion and then falling into a period of depression, and sitting in front of my primary care physician and saying to him, something's not right, and I can't quite put this together, and meaning my life. And he leaves and he comes back with a 7-page printout with 3 columns of names on each page. And from there, it was for me to literally play a game of pick and choose. And I ultimately saw 3 therapists before I found a therapist who I made a strong connection to. And what I would later learn is that my experience was not unique. In fact, 50% of African Americans terminate therapy prematurely because of the lack of therapeutic alliance, provider fit. We frame it different ways. And by the way, that number is 33% for the general population. So my answer to your question is that there's something like fundamentally wrong with our mental health care system. And I think that when we start this conversation, that we have to underpin it in that frame. Like we, over the last several years, although we've made some progress policy-wise, we've literally seen our mental health care system dismantled. And when I think about the system, by the way, I'm thinking of making sure that people with low to moderate mental health issues can get the care that they need, all the way to the most severe cases as well. So thank you for letting me drop that into the conversation, but I'm excited to keep this conversation going.
Absolutely, and I'm just going to put in the chat, says kick off the cat, that there are 3 phrases already that Kevin, I'm just going to start using these. John Henryism, I want to learn a lot more about that. Culturally intentional was in your bio, and cultural humility. And okay, I'm going to get a bingo card out because I just want to start using those words in my own vocabulary. It's awesome. So let me go ahead and talk, as we move forward, just talk a little bit about even the ability that Kevin just had to share his own story about that 10 to 15 years ago versus today. Thank you for doing that, Kevin. Very powerful. And I think the more we have people sharing their story and their own struggles, the more we get this into the spotlight. Maybe not, we can't get it all integrated into whole health, which we'll get on that path. So let's talk for a minute. We've got to address COVID in a minute, but right before we do, let's talk a little bit about pre-COVID. So we're 15 years ago now, maybe 18 months ago. Where were we? And Danny, if you would be, just to kick us off, talk us a little bit about where we were right before COVID started in terms of the mental health journeys.
Sure. So I think there were some good signs. So as I mentioned already, we had passed national parity laws, and there was a growing recognition of how common anxiety and depression are in our communities. I think that's true. There was also a growing awareness of the overdose epidemic and a starting to shift idea of thinking about substance use not as a moral failing or a lack of discipline, but rather as an illness in its own right. I think those things were happening prior to COVID, although we still had a long way to go to normalize them. But those were good signs. Some opportunities for screening, for depression screening in physical healthcare systems, lots of work on integrated care and some of the things that we've just talked about as things that were really lacking 15 years ago. So we had set a good stage, but access to care was already a problem. Stigma was still a problem, and disparities was still a problem, whether it be racial or sexual preference or gender identity, et cetera. There were many differences in how much harm mental and behavioral health caused in particular communities. So we had come a long way, but there was a lot that was still unmet as we entered that pandemic, this pandemic.
The one we were all living in. Anyone else want to add in?
Yeah, if I may, just it's interesting because I think, at some point we're going to frame this historically post-COVID, after COVID. But I think this question is spot on. And for me, it gives me an opportunity to really center around like this. I really want to lift up this question around the disparities that we were seeing even before the pandemic. Before the pandemic, African Americans were 20% more likely to experience serious mental health issues. And as Danny just alluded to, there were all these assumptions around stigma, and there are some of those things are really true and cemented into life. But African Americans are more likely to experience problems and less likely to receive care. And the same was across the board for other minorities as well. Now, what we've seen amidst the pandemic is something I think those of us who want to see people access care, we're proud to see that, but it's also really a sobering fact. And that is that we've seen an increase in treatment-seeking behavior, particularly among African Americans and Asian Americans, which have like the largest increase in treatment-seeking behavior. I think this is really a telling fact because it tells really how impactful this pandemic period has been on certain populations. And although we're still enduring this, I'm convinced that this is going to be sort of one of the legacy issues that we will have to deal with in the aftermath of the pandemic is how do we help people recover? And I actually think that we should start framing this from this very traumatic event that we've all experienced collectively. Some of us have sort of not been as impacted as others, but many's lives have sort of literally, they've lost the life that they once had through this pandemic. And so it's been a very traumatic experience. And I think has heightened and increased disparities and we're just now really beginning to understand that.
Absolutely. And I think as we start to look at the suicides that unfortunately are also coming out of COVID, Kevin, a whole nother thread we could go down is the some really sad statistics around African-American male caregivers under COVID who are now, increasing chances of suicide. And so, there's all these individual micropopulations we can start talking about. And I think that is one of the things that treating these as micropopulations, really looking at those risks. But I want to pull on that COVID thread a little bit more. And just as 10 years from now, we go forward and we look back and we say COVID fundamentally changed how we look at mental health. What do you think they're going to talk about this? And Danny, we'll start with you if that's okay.
Sure. I think one of the things that we will fundamentally talk about is what Kevin just mentioned, is this growing awareness of the disparities that already existed in our communities that were just amplified by this collective trauma experience that everyone had. And I think it's important to point out the pandemic happened, at least in this country, at an intersectional time with a racial reckoning and a political event that was the election of 2020. And when you put those all together, that was a kind of constellation of psychological distress that many had never experienced before. And I think one important thing that folks will remember is that each person and everyone you probably ever talked to during this pandemic has experienced heightened psychological stress in one way or another. And the number of folks who report really high levels who had never had a psychiatric disorder diagnosed or even many psychiatric symptoms in the past now are for the first time able to personalize that experience and recognize the reality and the disruption of life and functioning that depression or anxiety or PTSD can bring, right? And that is new. I think that collective experience is new and hopefully will be lasting. I think it will be. So while it's super concerning, the silver lining that many of us have talked about is how long will this awareness continue? And I think it's also related to this physical and mental health connection. I think a lot of folks now have very tangible experiences of themselves or those around them that physical health challenges are resulting in mental health challenges, and mental health challenges are resulting in physical health challenges in ways that they had never had a personal experience with before. And so I think that, and I hope that one of the lasting impressions of this is that awareness. Now, I don't think it's all silver lining. I don't think it's all rosy. I think these disruptions also will have lasting effects. There are consequences to prolonged experience of anxiety, to prolonged experience of depression, not to mention, disruption of finances and things like that, that we know have psychological consequences. So I think there are some dire things, and I think it's super important. And we've been advocating for, increased funding for research and surveillance of these. This has not been typically something we've done as a nation, but we need to. That is part of the recovery from the pandemic. But I'm hoping that that's somewhat balanced by this new awareness and appreciation.
Stacia, you want to jump in?
Yeah, I think I would add a couple of things. First, I think Danny is spot on around the necessity around surveillance for some period of time now. It strikes me, and I'm not sure how much of this is pre-COVID, how much of this is post-COVID, but one of the observations that we think about a lot is that COVID will likely accelerate a more permanent adoption of things like telemedicine, online care support, those sorts of things that were frankly poorly, the utilization of which was poorly penetrated both by practitioners and by patients. Now, interestingly, the availability of internet today, when I think about, our earlier conversation about relative to 15 years ago, is that Part of what has destigmatized mental health is just the more common discussion about that in the public forum, often online. Now, I do think that that is a double-edged sword. With that has also come a rise in cyberbullying. People often feel like they're cloaked in anonymity when they are commenting on things online, when frankly they're not anonymous. And so I think that that has, in some ways, driven a culture of us valuing ourselves and our contributions to the world in which we live based on, social media impressions and likes and friends and, all of the accoutrement of social media today. But I do think that there is an interconnectedness that people can engage in that has been helpful, that in some ways may persist well past the pandemic. And I would hope that things like telemedicine and some of those concepts that have frankly been around for 25 years, just not well utilized, will stick for a longer period of time. I would echo the comments about how COVID has heightened real and persistent disparities in outcomes experienced by people of color. I also think it has highlighted the digital divide. And I think that is a place that we collectively are going to have to lean in and figure out what we're going to do about. It is now true more than at any other point in time in my career that access to broadband access is actually access to care. And so when I think about the places and the folks for whom the situation we were all finding ourselves when face-to-face care became less and less possible, and the crises that created, that left more people behind when they didn't have access via broadband. So I think those are some additional concepts that are going to persist beyond COVID.
Questions that I'm getting in the chat too, and I want to stay on this for a minute. This access issue, the supply and demand that we have coming for mental health, treatments. How do you guys? Let's get it very technical. We just talked about broadband. We just talked about that. What is the kind of one thing you would say? COVID. Now we have this high demand. What is the first thing we need to tackle to get more access, more availability to the people who need it the most right now?
I can speak from my perspective as a carrier. I will tell you, we have thousands more providers with all kinds of excess capacity, and we have less ability to marry supply and demand today. Now, I think some of that is because of our own real personal preferences. If I need cardiac care and I need to see a cardiologist, I generally speaking don't say, I only want a woman who trained at this kind of an academy, who practices in this way. I mean, there's lots of things. Gender might certainly be a preference there, but generally speaking, we don't sort of list as many preferences about who we engage with in a physical health status as we do when we engage in mental health and substance use care. That is a reality. But I would also say that equally as important, many mental health and behavioral health providers are independent practitioners who frankly just don't have the infrastructure to help tap into the supply of patients who need extra support and services. So there's a disconnect between supply and demand. And so when I think about where we're focusing some energy, it's in identifying sort of the characteristics of and practice patterns or special, areas of specialization for our mental health communities, so that we can actually marry them more effectively to the people we know need and who are asking for care. And so, I think that's one problem. I do think we are going to hit against a reality that there's probably going to be more needed than there is capacity, and that we're going to have to get upstream into schools and training and understanding how to inform the workforce of the future to meet those needs. But for today, I think, the first thing we can do is begin better marrying supply and demand.
Let's put that PCP discussion also and how they can work in just a minute, because we're going to need some questions about that. Kevin, I don't know if there is a better softball question for you in this panel. Then what can we do about this? What is the thing we do other than need to learn more about your company?
I was literally on the edge of my seat since Stacia was talking. I mean, literally, I'm like almost.
You choose me. Yeah, that's right.
But, let me just say this. I agree with so much that she has said here. And I do think that we have to have a multi-pronged approach here. Let's just go all the way to the very beginning. We have to come to terms with even our best therapists are not trained to take care of everyone. Like, let's face a hard truth here. The mental health care system as we know it has been designed for middle-class white families, right? And why do I say that? Our research and learnings is based on research from middle-class white families with one trauma. That is problematic at face value. I don't care how you look at it. So we have to consider this issue of training. And as we have sort of all weaved into this conversation, when we consider the inequities and we realize that more people of color, people from underserved communities are seeking care than ever before, we know that we have a supply-demand problem here. More importantly, the supply that we have is not equipped to take care of everyone. Less than 4% of our therapists in this country are people of color. And let me go a step further here. This is where I get super excited about this and passionate. Therapists want to do what's right. That's why they're in the profession. But if they don't have the bank of experiences and the tools to engage people who they don't have similar experiences in life to, the therapy may not be successful in most cases. And that's, that, by the way, is our secret sauce at Hurdle. We train our therapists in an evidence-based technique that was developed, Danny, by the way, by Norma Devines at Johns Hopkins. And the deal is here, I know that technique works because it's the technique that I was engaged in. So that training and rethinking how we train our therapists with our workforce is critically important. These issues of broadband, we sort of framed it as telehealth, and I want to go just to call it telemental health right now. Like, this is really the way that we meet the demand. And this market, by the way, is exploding. There are several companies like mine that are sort of emerging with new solutions, trying to sort of get ahead because we can see the writing on the wall of the demand in the marketplace. Not all of us are going to be successful. And the thing that scares me the most about some of the companies that are emerging is that many companies are sort of just putting lipstick on the pig. And I'm going to speak pretty candidly here, and hiring models of color, but not reconsidering their approach to care. We have to fundamentally do this. And if we don't do this, the consequences are going to be long-term for us and severe. So listen, I'll stop by saying this. I was really encouraged when the Surgeon General made it clear that mental health will be among his priorities. And I, for one, I would invite all of you all to join me in this. This has to be like a national mandate that we ready our country to rethink our mental health care system with these fundamental underpinnings.
Oh, I can't wait for the public health professor to get on stage here, Danny.
I know.
I've just been like, come on, Danny.
And I was heard angels in the background, I think, as Kevin was ending that. So I even hate to say anything else. But I do want to add, much like this point about training our providers, I think the type of provider is something we need to look at when we think about reformatting our entire system. And that's to say, lived experience in terms of race is clearly one of the things we need to consider. Lived experience in terms of experience with psychological distress and substance use also. And so peer-based models really have an evidence base now, but are not always reimbursable. And the financing around them is not pristine, is my understanding. And so that is a place where we can think a lot about what the evidence base shows us and can deploy a different kind of workforce. We do have a deficit in workforce generally, and we are not necessarily thinking about driving that workforce in the ways that might be most beneficial to folks, in addition to the tele-mental health and other strategies that I think we really need. And then the last thing I would say about that is, I think one of you already mentioned it briefly, if we think about public deployment, sort of population mental health, the two things that always come to mind for me are education systems and employers, right? You know, if you want to touch the population of children as they develop, we have to partner with education systems. If you want to touch the majority of adults, even adults with mental illness and behavioral health problems, they are mostly employed. I mean, the vast majority are employed. So employers are these partners, and there are many, many challenges to getting this right. And you guys listening and on the panel know them even better than me, that go from legal to stigma to financing models, et cetera. But that is the thing we have to tackle. And so if we could do that, education partnerships, employer partnerships, and if we could think about what we mean by a workforce, from peers all the way to psychiatrists and everything in between, if that's even the right poles of that, that might not be the right spectrum to even clarify. But that I think could really change our system.
Danny, I think one thing you didn't pull on there, though, was also following the money. Who's paying for this, and how can we fundamentally change some of the reimbursement? And you just talked about groups, so I'll turn over to you in just a minute, Stacia, to talk more about that, to kick us off on that financing. We did get a question in the chat about also the value-based care. So Stacia, I'm just going to turn it over to you. How do we pay for this, and how is that changing?
You know, that's a really important question. The fee-for-service reimbursement chassis is actually part of the barrier here. So let's just use, Kevin, you know, to tag onto your comment around telemental health, telebehavioral health, telemedicine in general. What gets covered, when, by who, with what kind of cost sharing for people in a fee-for-service environment is actually a barrier to progress. As a carrier, I shouldn't care if care is delivered face-to-face, via televideo, via phone call, email, SMS, chat, text, carrier pigeon, smoke signal. But like really, that should not be the issue. It should really be moving towards value and outcomes oriented models rather than volume-based models. And the reality is that every one of those ways of engaging with people, when we're paying for care on a per click basis, that's problematic. So I think rapidly accelerating the shift to value and outcomes oriented models is a way to eliminate that barrier. It's a way to eliminate the barrier associated with cost sharing for patients. I see that as one of the legs of progress here. Obviously, addressing the digital divide will be important, and marrying access is important as well. But I think going hand in glove with value-based care is also the understanding and capacity for evidence-based medicine. And so there's already a ton of evidence, although Kevin, to your point, I think that's a really interesting observation about from what population was the evidence gathered. And I think that that's a place we probably need to look more. But, you know, we know that CBT, medication-assisted therapy, DBT, you know, there's a pretty wide and growing body of evidence that supports those. But today, that's not part of the rewards, incentive, or disincentive system. And so we really need to help accelerate that in the marketplace, because that will actually move the whole field forward, but it will also move the reimbursement field forward. I think, you know, you mentioned employers, and I would tell you that just as we are all feeling the strain of the impact of COVID in our personal lives, our professional lives, in the lives of the people that we serve, one of the stakeholders we serve is the employer community, and they are also feeling a lot of financial distress over the reality of the economic distress created by COVID. And so, the employers will continue to look for ways in which to arrest their rapidly growing healthcare costs. And this is an area they focus, like, show me that it works, prove to me that it makes a difference, prove to me that it makes a difference across all the populations of people that I employ. And so I would say that is not that burden is not put on the provider system alone. That is something we collectively have to do in community, in provider, in public health, in the payer community, is figure out how to understand what's working well, and then escalate and scale those things that are demonstrated to have the most impact on health outcomes for the people that we serve. And when I say health outcomes, to me, mental health is part of our health. It is not mental health outcomes, physical health outcomes as two distinct silos. As we've talked about through this whole conversation, one has a very significant impact on the other, and we have to address them in concert.
Kevin, why don't you, I know there's everyone's sitting on there. Kevin, did you want to jump in next? Or do you want to, you can take it. Kevin, I know you have so much to say, so I will just let you,
I just want to
write your own question.
I just want to qualify one thing I said. I wasn't sure saying throw the baby out with the bathwater here. We do look for therapists with deep experience in CBT and trauma-informed care. I just want to qualify my statement and say that what I think is important is that we overlay that training with some cultural competence and cultural humility. So I didn't want anybody in the audience or even my fellow panelists to sort of think I was saying throw the baby out with the bathwater here. But Jessica, there is a question that came for me here in the chat. Would you mind if I just try to speak to this?
Please do, yes. So,
and the question is from John Mitchell, and I don't know the exact answer to John's question. And so what I want to do is respond to it in a couple ways. Number one, historically, we must remember that the therapist community did not believe that African Americans had the cognitive awareness for talk therapy, that they would be good candidates for therapy. Like, that is proven data-wise. So when we see mental health issues, so the question here is about African Americans being 4 times to have a diagnosis of schizophrenia, right? What I do know for sure is, for example, when I was depressed, my depression showed up in ways that it does not look like in other populations. I was angry, short-tempered, and everybody around me just thought I was being undesirable or upset with them. But it was literally, those were the symptoms. And so again, to this point, one of the common things that we've heard in this conversation is the need for more research and understanding, because we need to understand these symptoms and how people show up and what progress looks like. So, I guess my response to John's question is somewhat loaded, is we have to understand the historical trajectory of how mental health care has evolved, but there's also this need for research to help us better understand how these conditions are showing up in different groups.
Can I jump in on that, Jessica?
Yeah. I was about to say, Danny, I think at this point you just write your own question. You could choose one.
To Kevin's point, this historical context is super important. But even today, there's pretty good evidence of diagnostic substitution, diagnostic preference by race and other contexts, right? And so you need to think about, why is a diagnosis of schizophrenia being made? Does it have to do with institutionalization? Does it have to do with particular prescription or medication or some other reason? And then what is the sort of personal bias or just lack of training by particular providers making those diagnoses? So, we're always, when we're looking at these kinds of trends, we're always trying to read between the lines of, are these true differences in a psychiatric condition, or are they because of this constellation of things happening in the background? And so I just want to echo what Kevin said and add to it that there are many things that can explain that are not things that we should pursue as true differences, but rather as perceptions and diagnostic preferences. Now, I can't tell you for schizophrenia that that's the only explanation, but that's the first place we go when we start thinking through these observations.
Thank you for adding that. That's a great point.
There was a question in there also about some of the digital, I'm going to use the word there because it's from the digital self-help tools. And I know we've talked about the online CBT, et cetera. Can you guys talk a little bit about, is that a mechanism we can address some of these challenges?
From my perspective, I think there's a place for it. I certainly would not see that as the panacea for all conditions. It's not, therapeutically appropriate for everything, but I certainly think it has a place, just like peer support does, in the arsenal of interventions that we have to help people. I think of that in the context of today we have an illness-oriented healthcare delivery system. Whether we're talking about illness on the physical health side or on the mental health and substance use side. And I think that as we look to things like wellness and lifestyle management to stave off, many conditions on the physical side, maintaining a healthy weight can help stave off the incidence of type 2 diabetes. There's a great example. I think there's an equivalent around self-help, resiliency, therapeutic interactions with peers that can be really helpful. Now, I do not think that those necessarily are the fix, if you will, for serious and persistent mental illness, and nor am I suggesting that it should be. But I think there's a place in the toolkit for that for people. I think we have to be realistic about what we can expect from those tools and supports, and use them appropriately. But from my perspective, yes, I think there's a place.
Yeah.
So Kevin, jump in.
If I may, your question reminds me of a book I read that I would really recommend to people. It's a book by a psychologist named Stephen Joseph, and the book is entitled What Doesn't Kill You. And honestly, I'm not a therapist. I should admit that, because people often think when I participate in this discussion, I'm a therapist. But that book is really one of the foundational reads to how I think about mental health. And Joseph attempts to redefine how we see trauma. And he even equates trauma to, for example, my son tried out for the lacrosse team last week and didn't get accepted, didn't make the team. So Joseph would frame that as a traumatic event. And so what he talks about when you have these traumatic events, and I'm getting to your question, Jessica, if you don't have the right coping skills, that what will happen is you're going to have a downward spiral. But if you have the right coping skills, that event becomes a growth opportunity and you experience post-traumatic growth. So when I think about like the digital tools, and even when I think about our product and what we're building, what we're trying to build is a tool to equip people with more coping skills. I think somewhere along the way, maybe in industrialization, I'm not sure exactly how it happened, that we've lost our coping skills of how to deal with setbacks. And maybe it's sort of like materialism, all the things that's going on in the world with social media, but people want the life that they wanted right now. And they're not really equipped with disappointment. Now, When I say that, I'm not saying that to take away from traumatic events that people have that are beyond their control. But what I'm essentially arguing is that we have to do a better job collectively. And even someone mentioned in the education system and employers, but if we start to rethink mental health and we start to frame it as that we need to equip people with coping skills, I think we're going to really advance the mental health of our country if we think that way.
Awesome. And I just actually put in the chat, if there are other book recommendations that this group wants to, this is such a rich, I know a well-read group, especially that we're all trying to learn more about this. But one of my favorite panelist questions, talking to experts such as this, is what is the one statistic that you wish we all knew, we just were carrying around in our back pocket, that we really knew about this? It is, and Danny, I know you spend your life in biostatistics. Let me start with you. What is the statistic you wish we all knew?
I can't resist but giving two. The first is 20 to 25% of people experience a mental or behavioral problem every year. This is not a rare event. These are common things, much more common than many of the things that keep us up at night. And another that I have to give you is the suicide is preventable and is yet so high. Second leading cause of death amongst our adolescents and emerging adults. And that is something that I think everybody should keep at front of mind because it is preventable and at least double the likelihood compared to homicide. And we spend so much of our collective energy trying to prevent homicide. So I'll get off the soapbox.
No, that is a important, and just, yeah, the way, that's an important soapbox to be on. Stacia, any statistics from you? And then I'll turn over to Kevin.
I was just going to say, Danny, move over on the soapbox because I'm right there with you. I would tag on to that less than 10% of primary care providers regularly screen for depression. Now, that is better than it used to be, but that is, that's a startling statistic. Yet we see, and we can see it in the data, over 60% of psych meds are prescribed by non-psychiatrists, and about 70% of treatment for mental health diagnoses are happening in primary care, often because that's where patients prefer it. So they see their primary care provider as a whole health provider or a whole person provider. So thinking about how we strengthen the capacity and ability to address depression, anxiety, and these, as you well pointed out, very common conditions in primary care is really critical.
Kevin, any statistics from you want to share?
Yeah, I'm sorry, I was on mute there. I would share that rates of suicidal ideation are the highest among youth, especially LGBTQ youth. Like, we've not talked much about that today, but I think that that's a really important piece to share, that like we've sort of been, I think, centering our conversation around, not that we've called it out exclusively, but it's felt like we've talked mostly about adults in this conversation. But we really have a severe problem with our young people. And when you dig deeper into the data sets around young people and try to understand like what's taking place, it becomes very, very scary. For example, when we look at young Black men who are committing suicide, they have not had any public sharing of ideation. And the researchers believe that they're making spur-of-the-moment decisions because of their sense of hopelessness that they're gathering from their self-image in the news. So I really think, in addition to sort of this national cry we're going to try to make to collectively, all of us, right, to get some energy around rethinking our mental health care system, there has to be a focus on the youth, and we have to dig deeper into what's happening among these select populations to really understand it.
I feel like going back to Danny again and asking for some more statistics. I'm writing them all down so frantically so we can have that. I want to turn it back to just a closing thought, and I'm going to start open up for the panel because we just have a minute left. We talked, and can we just use the word hopelessness? And I think that is so much of how we address that. It's incredibly challenging. And I'm very hopeful as I sit here and listen to Stacia talk about how we can change payment and Danny, how we can do the research and fundamentally change, and Kevin talking about new models that are coming. There is hope there too. So Danny, any closing thoughts from you?
Yes, mental illness is preventable. Most mental health symptoms are preventable and absolutely treatable. If you question me on the preventable part, absolutely treatable. There is hope, and these are solutions that can make a huge difference. That's what makes me happy. I actually do genetics work, which may or may not be as modifiable, but I can tell you these are modifiable things that have solutions, and we just need to seize the moment to be able to make that change.
Awesome. Real quick, Stacia, turn it over to you and to Kevin.
I would tag on to those comments, and I would say we collectively need to shift our focus upstream. Today, we are still far too often treating mental health when it has in fact become a diagnosed condition, and that we need to focus upstream where people live, learn, work, play, on the causes of those preventable conditions, such that we aren't just always chasing our tails.
Yeah, I would add, first of all, Jessica, thank you for doing such a beautiful job moderating this discussion. This has been so exciting. I am incredibly optimistic about the mental health care system. I think conversations like this are the beginning of a new era. And I am doubly excited about the honesty that we're having in these discussions around disparities and equity. And I don't think that we will ever return to the way that things used to be. So I'm ready to roll up my sleeves and work alongside all of you all in rebuilding our mental health care system.
Well, it would be a privilege to work with any of you in helping to fix this and get the next steps forward. Thank you. And thank you to MedCity for having the opportunity to have this panel today. Thank you all.
Thank you.
Thank you very much, Jessica, and to all the panels for a great discussion. I think what really struck with me is something that Kevin said, that we are not teaching people coping skills. I'm an immigrant to the US, although I've lived here for a really long time, since 1999, and it always bothered me after I had kids that any chicken scratches that kids do is put up on the kitchen refrigerator as a work of art. We are coddling our kids way too much. And so it's not a surprise, Kevin, that they do not know how to handle a setback. So I really appreciate this panel's comments so much, especially given the differences in our experience with mental health based on lived experience. I think that is so true. I mean, it's not just the idea, what you said, Kevin, about therapists are trained according to the traumas that white middle class faces. I'm a person of color. I don't think I would be equipped, even as a trained therapist, to talk to a Black man who has experienced some of the inequities in our nation. So it has as much to do with the race as I think it has to do with income level as well.
Absolutely.
So, again, thank you so much for this great discussion. This will be recorded and it will be available to all our attendees, and we will put this up on our website as well. I just wanted to close with a quick housekeeping. We have our Invest Pitch Perfect coming up at 4 Eastern, which will be 1 Pacific, and we will have a pitch contest with biopharma startups today. So thank you very much for attending, and I will see you shortly again.